Welcome, welcome. So good to see everyone. Happy Wednesday. It is a leap year. So this is leap year day, February 28th. It's so weird, but fun and exciting. I have a good friend who both, like her mom's born on a leap year. So her mom's turning in her mind the same age as her daughter. So they're doing a joint birth. It's so cute though, because I'm like, this is hilarious, that the grandma's turning 15 and the daughter's 15 and it's fun. So anyway, happy leap year. Good to see everybody. It is Wednesday.
My cousin was born on a leap year, and he'll do like his birthday party, and we'll do like kid stuff, like laser tag, because he's like technically like 7.
See what I mean? Yeah, have fun. You get to be a kid forever if you were born on leap year. So kudos to you. Y'all are so young. You look great. Good to see everybody. Love you guys. So happy y'all are here. We're already getting lots of comments and questions, which is awesome. So a couple of reminders. Today's live stream is, of course, always intended to be educational, not replace therapy. And of course, IOCDF and or our live streams are not crisis lines. If you're feeling unsafe, suicidal, or in crisis, please call 988 or go to your local emergency room. And if you are outside of the US, follow your local resources for support. As always, throughout today, if you guys have questions, comments, you want us to talk about stuff, please put that in the right-hand pane so that we can make sure we get to it. I am so excited for today. You guys, one thing I will tell you, one of my 2024 goals is to become more clinically competent in BDD. So yay. So I was like, oh, last night, like, I hope I can ask a million questions. So when Chris said you're going to lead, I'm like, that sounds great. This is going to be all the things I want to know. So I hope that's all the things everyone else wants to know. Kidding, but not really. So yeah, today is such an exciting day. We're going to do an entire webinar focused on BDD. And I'm so excited because we are going to get to hear both clinical and personal experience. And we're really going to dive in. My goal for today is that listeners can understand what BDD looks like, how BDD looks different than OCD. So what makes up BDD diagnostic criteria, but also what makes treatment different? What should we be doing differently? How does treatment look a little bit different? And of course, we'll talk a lot about comorbid depression and other things that often go hand in hand with BDD. So Chris, as somebody who talks a lot about your own personal experience, I'm so excited to have you really be able to give this incredible personal background. And then I know that, Robin, you bring this wealth of knowledge around BDD from a professional perspective. And of course, you have so much incredible content to both online and everywhere that we use, we love. So we're excited to talk about that. So people know Chris, we're going to skip him. And I would love for you to just introduce yourself a little bit, a background of like why you do this work, what you love, and just kind of who you are and where you're at.
So I'm Robin Stern. I'm a licensed clinical social worker, a licensed therapist. I knew I wanted to help people. I didn't necessarily know I was going to share my own journey of struggling with body dysmorphic disorder. I was diagnosed over 20 years ago, and it was actually through the OCD conference in 2016 when I really felt connected. And I said, this has to be part of how I am as a therapist. I need to show up, and I need to show up authentically and bring my own personal experience and be able to share what BDD actually looks like. And I really feel, for me, there's been a lot, even more recovery through unmasking it. So much of BDD has been shame. So for me to be honest about it, open about it, was something I never had planned, but has just kind of taken off. And I feel so blessed to sort of be in this platform where it's acceptable for clinicians to be able to share experience. I bringing in my mom, she's like, are you sure you should be sharing that? And I'm like, no, Mom, it's okay. People need to hear it. She's just and I'm like, that's what they're connecting with. And the truth is, that's what I didn't have. And I just always sometimes wonder, who would I be, or what would I be if I did have that? Right. Yeah. So this has sort of been taking on a journey of its own. And, BDD is definitely something that has impacted my life. And I always say, I just want to be the therapist that I truly never had. So I'm so passionate about body dysmorphic disorder and getting the right message out there. And so I'm just so grateful to be here today. So thank you.
Liz disappeared on us. That was so compelling. I'm going to take a break. I'll jump in until Liz pops back on. No, I do think that's one of the things on a clinical level that we all have to decide as therapists if we're going to open up. And one thing
Right.
I've noticed is a lot of therapists do. Oh, there Liz is.
That was crazy. It just like glitched. I was like, oh my gosh, did everyone get kicked off or just me? What the heck? Oh, Robin, I just want to, I love your intro, and you are definitely in a safe place, and in a place where, you know, I think both can be true, right? I think that we know individuals need competent, great clinicians, but there is something to say for lived experience. And when there are clinicians that can integrate both, like they're a competent clinician, you're not treating based on your own personal experience, you're treating based on your clinical expertise, but you also have empathy. You can relate more than anyone else ever could, because you know what it's like to also have walked that journey. Is so incredible. So we're so excited to have you here.
Thank you.
Chris, I know a lot of folks know you as a clinician, and many know a little bit about your background, but would you share a little bit about why BDD is so important to you?
Yeah, no, I mean, like many people, I didn't even know I had an OCD diagnosis until finally finding the International OCD Foundation and getting a trained therapist to diagnose me. And what was different about OCD and BDD, because I have both, is I was so open to my therapist about my OCD intrusive thoughts, even though there were things like harming family members and being sexually aggressive. And for some reason, even though I was comfortable talking about those, I was very, very uncomfortable talking about my appearance-based obsessions. I felt very shame, I felt guilt. And I think what was different for me is I actually felt like everything I saw in the mirror was true. So I didn't necessarily know it was a mental health condition. And finally, when I was opening up to my therapist about why I was doing certain compulsions, some of them did tie into my appearance. I was extremely lucky that my therapist also had BDD, and she recognized it in me. And she said, look, I'm not an expert. I'm not, I don't treat it, but there is someone locally who does. Why don't you do an assessment with him? I think you're showing signs of BDD. And when I went and did the assessment with Ari Winograd, I burst out in tears in my OCD assessment because it finally felt like someone got it. And it was the same experience with BDD. It was like somebody finally understood what I was going through and helped take away like the shame, the guilt, all the feelings that I was feeling. And so for me, when wanting to become a therapist, part of it was, of course, because I know that although there's barely any OCD therapists, there's even less BDD therapists. And I just really wanted to provide treatment so people could get diagnosed earlier, could get education earlier, and get treatment. So although it's a personal thing, part of it to me too is I just don't want other people to suffer like I did. There's so much shame behind having BDD.
Yeah, so let's start there. Let's talk a little bit about how BDD diagnostic criteria looks different and how it presents differently. So Robin, why don't you share a little bit about just what are some of the basic signs and symptoms of BDD that people might see or people might be experiencing?
So I know one of the things that I've gotten with a lot of clients coming in saying, well, who are you to say if someone's pretty or not? I said, this isn't about, identifying if someone is pretty or not. It's about you're coming in with feelings of a perceived flaw that objectively nobody sees, right? So I think that that's where, it's not about a judgment. Is someone pretty? Is someone attractive? If somebody, let's say, is coming in and saying their face is just aesthetically unappealing, or their bone structure is off, or their nose is extremely big, and you objectively look at this person and you can't see what they're seeing. And then a huge part with BD is just the how one doesn't function optimally, and you lose the ability in almost every aspect of your life, your ability to function. It interrupts your level of functioning. And I think what we see with BDD is a very big continuum. I was definitely a highly functioning BDD girl, but I was like in my head 24/7, like walking around being like, I'm gross, I'm disgusting, I'm different, I'm worthless, I don't deserve to be here, like I'm defective. And these were like the constant thoughts that were coming on my head as I was still like entering college, walking around. That was before my diagnosis. And I think, a big part of the BDD diagnosis is what you perceive objectively, others don't. And then we look at their level of functioning. What have you lost to it? And I think that's a big thing, because we are seeing a lot of like body dysmorphia, and that's more highly correlated to body image. And so we want to differentiate too. And like a big thing when we're looking at it clinically is, what are you losing to it? What are you losing when you have BDD? What part of your life has changed for you?
Yeah, and I think that that's such a good thing to make sure that we differentiate, is because so many people are aware of trends, and that's one of the things that we're all really trying to do, is make it clear that body dysmorphic disorder is a very different disorder. There's very specific criteria. So somebody who matches the criteria of BDD or body dysmorphic disorder, they see a perceived flaw or flaws in the mirror, and they don't think that it's slightly unattractive. They feel like it's disfigured, it's noticeable, it's embarrassing, it's shameful. And because of that, they do rituals or avoidances. So some things are like camouflaging, maybe wearing heavy makeup, or avoiding leaving the house, or a lot of comparison. And it's causing a lot of distress. And what we see in BDD that's different than OCD is lower insight. So the individual comes in and doesn't think that they need a therapist. They actually think that they need plastic surgery, cosmetic surgery, or unfortunately for some people that are severe, they feel like it's beyond help. And so therefore they just have to live a life of like shame and hiding out in their home and don't leave the house unless necessary. Whereas somebody with body image struggles, or what the term body dysmorphia is, we don't want to discount that. That doesn't mean that somebody isn't really struggling,
Right.
but the difference is that it's not constant. BDD is a constant chronic disorder similar to OCD. That doesn't mean you can't get better. That doesn't mean you can't live the best of lives. But what we're trying to say is it's a consistent experience. Body dysmorphia, somebody may feel uncomfortable in a bathing suit during the summer, or they might have a breakout and feel embarrassed, but it's a temporary experience. There's
Right.
discomfort. And typically, sure, they do think the thing looks worse than it does, but other people can also see it. And we may not judge it or feel the same emotions, but we can see it and we can recognize it. So that's the big difference between, BDD and body image. And I think that's important to clarify, because the treatment is different and the diagnosis is different.
I was just going to say, what has really even supported me in my own diagnosis and with my clients is what, Dr. Jamie Fusner has done with the functional MRI studies. And I think that's important. I think I try to get this message out there that our brains don't process our image accurately. And I love seeing that functional MRI study. And I know they have it on the IOCDF webpage. They're showing that our spatial processing is different and how we perceive ourselves. So this is not just we don't like it. This is how our brains are looking different than those brains that don't have it. And that was definitely comforting to me. And I know I wish I had that sort of support 20 years ago to sort of know that. And I think that's a really positive direction with the research we're going to seeing that this is, and I don't know if they've compared that yet to like what someone with OCD has, but I know that they have with someone with BDD and eating disorder versus someone who doesn't have it. And so we therefore know a person with BDD cannot see themselves accurately. That's just an unfortunate part of what this disorder does to the person struggling with it.
Yeah, and I think that, let's talk a little bit about diagnostically. So we know kind of from a diagnostic perspective, these are perceived flaws or images that often other people do not see or recognize, right? The individual's preoccupied with this and it's causing extreme distress. And like Chris said, constant preoccupation, right? It's not, I'm having hormonal acne, like, oh, right, this sucks this week, but and it's real and we can see it and it's worse, but then it gets better. This is like a constant preoccupation with these perceived flaws that others don't see. But can we talk for a second about, as well, for diagnostic criteria insight? So with OCD, oftentimes individuals with OCD will be able to say things like, I know this doesn't make sense. I know this is bizarre, but I feel like I have to do it, right? The insight is pretty good, even if it's like, I may not have control over that, right? I still understand that this is irrational. Where I find that a lot of patients with BDD have much lower insight. So often it's like, no, but it is there and I do see it, and they feel like almost convicted in this truth. And so, yeah, can you talk a little bit about that from diagnosis, and we'll talk about how to deal with that treatment later.
Yeah, I can jump in first. With BDD, that's one thing that we see very different than OCD is there's a lot less insight. And in fact, most people are coming to our office not having a lot of hope. I would say the two biggest reasons that I see people come to treatment to see me is, one, I've actually had some ethical cosmetic dentists, cosmetic dermatologists, plastic surgeons, et cetera, tell a client like, hey, I've put in as much filler as I can. You keep coming back. You're not happy with it. I think there's something else going on. I think it's more of a body image concern versus actually needing the filler. And then the second reason I see it is because typically somebody's in so much distress. Everything cosmetic they've tried hasn't been working, and a family member or loved one steps in and says, I really think you need to talk to someone. I will say, although I dislike the term body dysmorphia because it's not a DSM term, I do say that there is a push of a little bit more understanding of it. So I think sometimes people will come in because they see more articles about it and hear it. But when people come in, there isn't a lot of insight. They are convinced that their appearance looks the way it does, and they're more so wanting to get some tools in how to cope. And so that's why the education component is so important, is because I'm teaching clients, look, I understand that you're in distress. I'm not going to argue back and forth about your appearance. I want us to recognize that this is a mental health condition. It's not about your appearance. And let's really work on that. I will give you relief and just work with me on kind of the program. But yeah, I mean, the insight is often low, and often there's a defensiveness. And that's something that we as clinicians have to take into account. If you sit there the first day and you're like, no, you look great, I don't see it, why do you think that? You don't have that. The person's going to feel invalidated and become even more defensive.
Yeah, I agree with that. I think insight for BDD is often poor. I think there's a continuum of that, right? So I think for me, in terms of my personal experience, I had pretty good insight, but it still was so distressing. And I think it didn't matter that I knew it was body dysmorphic disorder. Once I got it, I still felt defective. Like I still felt not worthy. And I think what I've seen in my practice is a lot of parents pushing the kids into treatment, and they're not necessarily minors. So I have definitely been getting a lot of clients that are not open to the diagnosis. They feel invalidated. And I definitely, as someone with lived experience, never want someone with BDD to feel invalidated. So, for me, what I tend to do is, if they're not open to the diagnosis, like I'll really go into the notion of, look, even if what you see is there, is this reason to stop functioning? Do we stop living? Do we stop moving forward? You deserve to live. And I think that's important, but it is very hard. And I think the insight often is poor. And I think it ranges. I think it ranges when you're in recovery too. I think when you have people come in who've been in treatment prior, you're going to have insight across the board. Some are going to be really good. I know for me right now, in my practice, I currently have a very high number of people with very poor insight. And it's a challenge, and it's a challenge to explain to the parents where they're at, because I think support for the parents, like they understand their child is struggling, but they can't really wrap their head around it. They're like, but why, like, I don't see it. So why did they stop functioning? And I just have I keep saying, it's the BDD, like, trust in what I'm telling you. It unfortunately robs you of things. And I do think insight helps in terms of motivation for recovery, but I also, and I know Chris and I have discussed this, I think when someone shows up, we have to give them that like positive, like, you're here to talk to me. And so we're going to start there. And I never want to turn people away, even if they're not ready to do the work. I think if they're open, that they're coming to a BDD therapist, I want to say that's a step in the right direction. Our goal is to get insight there. Our goal is for you to begin to see it, to understand it. But we also have to like look at like the glimmers of you coming here, of you being like, I'm willing to have this conversation. But I do think when I look at my clients with OCD versus BDD, that is definitely a big difference in terms of like getting treatment going and starting even just this CBT ERP. It's like, this isn't a mental health issue. This is an issue of like, I'm ugly, my face has changed, it has to change back, or I'm not going to continue to go through my life. And so it's like,
No, this is really, really helpful. And I think it's important to know too, that one thing I find is that patients with OCD kind of show up being like, tell me what to do. I'll do anything to get rid of these symptoms. And I like, where it feels like patients with BDD oftentimes feel a little bit less willing to be connected to their symptoms because of how scary and how real they feel. So there's a little bit more of like, I don't know if you want to call it enmeshment, that's not the right word, but like with their, what's going on, right? Like, oh yeah, you can tell me that, but like, it is so scary. It's so terrible. Like, I feel like there's a little bit less willingness to do the work with BDD patients. And so I would love to hear, as we start to transition into treatment, if that's valid. And if that means, are you spending a lot more time, like you just said, Robin, like in psychoeducation and in willingness way before you're jumping into the work?
sometimes you have to, and it's unfortunate. Sometimes I feel guilty of just the repetition of it, but I also have to acknowledge that if they're not ready to do the ERP, like, what are we doing here? And I know from my personal experience, like, I wish someone spent a little bit more time in this stuff, validating my feelings, the words that come up. And I know we're going to talk about treatment, but it's like, I don't hear it as much with people with OCD, like feeling worthless, feeling defective, feeling like they don't belong in this world. Like, I feel with my clients with OCD, they come in and they're like, I don't want to have these thoughts. And I'm getting a little choked up because I think about, that's not what I felt. It's not just about the intrusive thoughts. I just didn't feel like I was right. I didn't think not the just right. Like, I just felt just inherently defective. And like, because of my appearance, like, I just had no place here. And so through, definitely like talking a lot to Chris and just having a lot more, like comfort here with colleagues, have grown in that. But I will say that my therapist didn't discuss that with me. And I give that a lot to my clients now, because I was able to come out of the mirror. I was able to not Google, but I still walked away feeling defective, no matter how much I stop the compulsive behaviors. And I want to make sure that like I'm giving that back to clients. And so if I have to stay in that emotion a little bit longer and continue that emotion throughout our work together, I think that's going to be what's going to help someone sort of stay in recovery longer and it be a stronger recovery. And I am sure Chris can, attest to that as well.
Yeah, Chris, will you share like more about readiness too, and what that looks like, and what would make you say, okay, now my patient with BDD is ready to move from readiness to intervention? But I want to hear a little bit about like, what specifically are you doing during this time?
Yeah, absolutely. So one of the things that I am trying to do at the beginning stage, the two thoughts that I have is I spend a lot more time with the cognitive behavioral therapy component before ever getting to ERP in severe cases, because people aren't ready to give up like, layering makeup or wearing a hoodie out, et cetera. So the readiness that I start with is we have to get somebody with BDD to understand what's going on in their brain. And as Robin mentioned earlier, Dr. Fusner has been leading the charge in actual scientific research that clients can get that makes them understand that there is actually research that shows there's a multitude of things that are going on. So what we know is going on is, first and foremost, is they are getting very hyper-focused on minute details. The left hemisphere of the brain is lighting up versus the right. We see that in anorexia, for instance. And so the person has to know that. Also, that their visual processing and both their orbitofrontal cortex are misfiring and firing loudly, telling them that there's something wrong in what they see. We know that they misread faces. So when they're out, they're assuming that people are showing disgust-like faces. We know when they look in the mirror, they're not making eye contact with themselves. They're going straight to the flaws they don't like and fixating on it. And there's actually eye tracking software that a research lab in Australia did. So there's a great video that I show from that lab from Australia that really shows a patient with BDD going through all these different medical assessments to show how her brain functions different. Fusner spoke at the recent BDD conference in London, and luckily they put it online, but he goes through the psychoeducation of why somebody with BDD can see themselves with a wide nose or a weak jaw or really wide hips, even if other people don't. He also has a couple really good scientific articles and summarizes the research very well on the IOCDF's BDD website. So I actually go through that with clients. I show them both of those videos. That one's about 10 minutes, one's about 30 minutes. The articles take, a good 30, 45 minutes to go through each. But what I find with my clients is they want that answer before they're willing to move on. They need to know, why do I see something different? Because if they don't have an answer for that, they're going to keep being resistant. The other thing that I couple it with is there's a term, the BDD Foundation put out a really good graphic on this, but, talking about theory A and theory B in BDD treatment. So theory A is, you're right. You look the way you look and nobody else around you sees it. But you're convinced that it's wrong. Or B, the source of all of your distress is your preoccupation with your appearance, and it's not helpful. And so I'm getting the client to be open that maybe it's not necessarily how I look, but it's the preoccupation with how I look. Once I go through all of that, my goal is not to have the client like 100% like, yes, I know it's just my appearance. It's getting them to be open. So what I'll ask clients is, let's talk a little bit about how we got here. So one thing I do with clients also is a BDD timeline. So I'll go through every stage of their life and we'll map out what happened with their appearance. Typically I see in their pre-puberty ages, like 8 to 13 is when it starts. And what they'll notice is that their appearance doesn't always change, but the distress and the severity and just the overall just unwillingness to just be out in public and be around people does get worse, even if nothing changes. And what I'm helping them recognize is all of those stages, they haven't had people constantly mention their body part, point out their body part, make fun of the body part. It's all internal. And so by the end of that, that's when I can start to transition into the CBT. So I want the client, before we start the CBT process, which clients are often a lot more willing to do before ERP, is they're at a point where they're like, okay, scientifically, I understand why I see myself different. And going through that timeline, I recognize that all of my thoughts about my appearance are self-created, or they're very somebody mentioned something when I was 8. Now, we do sometimes see bullying in BDD, but often it's not even always bullying to the same level of distress they experience, or sometimes the bullying isn't even about the body part they don't like. So long story short, by the time they're there, the client is open to understanding why they're having the experience, and they're recognizing that a lot of this is self-created. And that's when I see the willingness to at least start with the cognitive part of the treatment.
And so when the willingness starts to happen, what are the first steps? We know that for OCD treatment, the first steps are us really getting a good understanding of what are your current triggers? What are your current avoidance behaviors? What are things? And so what does that look like for BDD? And then let's hop into details of treatment. Robin, do you want to start with just kind of what are the first things you do when it's okay, they're ready and they're here and they're wanting?
I think I like to know definitely their thought process, still continuing on that and sort of what they attach to. I always want to know avoidant behaviors. We're doing very typical CBT ERP stuff, but I think sometimes for my clients or for myself, we are seeing a coupling with sort of the little trauma type of things. And so it's about also disconnecting that and realizing when we're putting down the stuff for the hierarchy, we're also looking at how you're responding emotionally when those things are happening. So when you're engaging in those compulsion or avoidant behaviors, what is that making you feel like? Where are you going with that? And I feel that it's similar, the CBT ERP, the ERP model is similar to OCD in the sense of what are you avoiding? What are your, you getting reassurance, validation, announcing, all those things. But oftentimes I find myself less with OCD clients, more with BDD clients of what is your emotional experience during the ERP? How is it making you feel? And there's just a lot more that's coming from the client during those experiences versus someone with OCD. There's a lot more cognitive error coming along once a client is doing ERP. So, if the exposure is to go out into into Starbucks and be present, oftentimes you'll hear someone come back and say, this person was looking at my face the whole time. This person was definitely talking about me, and a lot of mind reading. So I feel like when we're doing the CBT ERP, we're often coming back to, challenging the cognition, altering that, looking at distorted thinking. And we're not just, it's not always that clear ERP. We always sort of have to go back in. And again, I think it varies from person to person. I think for some people, they're able to just do an exposure hierarchy and able to get through it. I think for others, they need more step-by-step and processing through emotional experience as well.
Yeah, I would say for me, what I like to start with is the cognitive piece. And one of the things I'm looking at is the person has gotten to the point where they're sitting in my office and they believe that they look the way that they look. And I want to help them understand, how did we get here? That's usually what I'll say is let's look at how we got there. And once again, we'll kind of collect the data. So they'll go ahead and they'll write out and they're like, okay, well, the reason I don't like my nose is because I'm comparing a lot to other people. And I'll say, okay, I get that. Let's look at the amount of distress you have, the amount of avoidance you live. How much, bullying or comments do you think somebody would have to get to that point to be then willing to want to get a nose job or to contour or to hide? And they'll say, well, probably somebody who is teased like on a daily basis, maybe like a family or a friend has said like, hey, like when you're 18, I'll get you a nose job, like things like that. But that's not the experience my client has. So I'm helping them understand that something happened usually when they were younger, and they've just sort of gone with it for all these years. And because of their response to those feelings and those thoughts, they've now created this like belief in their mind, this story in their head that they are now, you know, altered. And so like doing the more traditional cognitive behavioral therapy that we don't really do in ERP, often what clients will see is like when we're looking at all the evidence that, hey, maybe there is something wrong, it's usually very sparse. But when we start to go through typical BDD cognitive distortions, Robin mentioned one like mind reading, we'll start to look and there's a lot of distortions. And also there's a lot more evidence that it's not true. So, you know, for instance, a client might have a girlfriend and I'm like, okay, well, if your belief is that you're so hideous that no one can love you, you have someone that loves you. So there's a lot of confirmation bias where they're not really looking at the evidence that's proving that they don't look the way that they do. So through the cognitive behavioral therapy, which we don't spend time on really with OCD, the client is learning that there isn't much evidence or much reasons to believe the way that they believe. And in fact, there's a lot of evidence around them that maybe they don't look the way that they do. Then what I like to do before I go out and start the ERP is perceptual retraining, something that's unique to BDD that we don't often see in OCD. When clients look at pictures or in the mirror, they're often zooming in, they're focusing on parts that they don't like, and they're not seeing the whole picture. And we got to get them to see themselves holistically so that they're not, not believing that their quote unquote flaw is as big. So that's when we're going to have them look in the mirror. We're going to have them at a comfortable distance. It's not a long process because we don't want to teach them to stare in the mirror, but they're making eye contact with themselves. They're seeing their whole selves, and they're practicing using objective observation versus subjective negative thinking. And so once a client has gone through the cognitive therapy and the perceptual retraining, they're starting to feel different about themselves. They have tools on how to address the thoughts. And then like Robin said, the ERP is not in the OCD that we're like, hey, you're going to put a bunch of acne on your face and call yourself ugly and go up to somebody at Starbucks and do something, right? It's like, how can we get you back into just values-based living while dropping some of those compulsions? There's also a lot more emphasis on the emotions they experience because they typically do have a lot more internal experiences than somebody with OCD.
You know, I was thinking about what you said in terms of the girlfriend thing, right? Like, and I'm thinking about, I've had this conversation with clients where they're like, no, I have a boyfriend or girlfriend and they just feel bad for me. And that's why they're with me. And I'm like, I mean this in the most sincere, kindest way. Like, there's just people like that just don't exist. Like, they're not just dating you because they feel bad for you. But that's where some people with BDD go. Like, they can challenge you. They're really, that's why, like, I've spoken to a lot of OCD therapists who sort of sometimes don't want to take on a BDD client because it's a challenge. They'll challenge you. You'll come and say something to them and you're going to give them the evidence and be like, there's no evidence to support your thought. And they'll come back stronger at you and say, but this is true. And you have to be willing to, sit with them and understand where that's coming from. And I used to, I know myself that I used to sort of walk circles around my therapist and I knew what to say or what not to say. So I think, it's definitely, there's a lot more, I feel, belief in their distorted, and which is why that CBT part is so important. The CBT part for people with BDD is so crucial into challenging those intrusive thoughts, because without that, I feel like the ERP is just not as strong. Right.
So practically talking, are we doing like some thought challenging worksheets? Like, what are we doing if I'm a clinician listening and it's like, okay, I hear this, that like with BDD patients, once they're ready, we don't jump straight into ERP. We're going to do a lot of work on cognitive distortions and retraining and helping us understand both the why, but to be able to see this the way other people see it versus the way we see it right now. So what does that look like practically speaking?
So I think for me, I do use the list of cognitive distortions. I often have my clients track that and look at what they sort of, like I say, the lens of their life. And yes, it will be through thought record. I often want, a week, a day. I want them to sort of see how they're thinking. Oftentimes it's very similar day to day, but a lot of it is tracking the distorted thoughts they come into. So, when they go out places, what are they thinking? What are they feeling? And then also they are able to sort of couple it with a compulsion. So oftentimes when they're thinking or feeling like someone is looking at them, their next step to that, instead of really sitting with the discomfort, is let me go mirror check. Let me go see what I look like, right? So I do feel that for a clinician, it would be going over what those distorted thoughts are and having your client begin to track what their distortions are, what the thoughts are coming along with them, and what behaviors they're often accompanied with.
So yeah, so Liz, just practicality. Let's say you're my client and you came in and like, let's say your BDD focus is that you felt like your eyes were too close together. And like, we've already kind of started working together and we've looked at more like past history. How did you get to the point? And you're like, in 8th grade, there was this cartoon character that had like really close eyes. And someone in class said that I looked like that. And just ever since then, I've really like focused on it. I've looked online, I've looked at measurements, and I do feel that way, but there hasn't really been history since then. So as Robin said, let's say you've tracked the week and you come in, and I would say to you, okay, walk me through like when these thoughts came up. And so a lot of times I have people track the location that it happened so we can start to get some awareness training. What are some of the situations that you're in? So maybe you had a family event and then you went to like your sister's baby shower and then you had to give a presentation at work. So I would know that for you, a lot of your BDD is when you're front facing. Some people, it's not that. They could be at home all day and not care what other people think, but maybe based on your tracking, it's being out around people front facing. And then let's say I'd ask you, like, what were the emotions that came up? What were the experience internal? There was a lot of shame, embarrassment. I felt like everybody was staring and looking. And I'm going to ask you then, let's walk through the thoughts. And so your thoughts may be, other people are noticing my eyes are close together. They're wondering why I haven't fixed it or figured out a way to kind of camouflage. They're not taking what I have to say seriously. It's really embarrassing. And, I would ask, like, how did you come to that conclusion? And typically what the person will say is, well, I just know. And then that's when we get into those cognitive distortions. And one of the things that clients often do, like you would be doing if this was you as my client, is you're projecting. All your internal experiences are being projected to other people. So there's an assumption that people are as, being as judgmental as you are and have as negative of a reaction to your appearance as possible. And so I would challenge them a little bit and say, look, like, I need to know how you came to that conclusion. And often the client won't have a good reason. It's mostly like, well, I just felt that way. And I'll ask them, okay, well, is that how you do other things in your life? Like, do you just buy a house? You don't even like look at it. You just feel like it looks good and you buy it? Well, of course not. So I tell clients, the good news is I'm not teaching you new skills. I'm using the skills you already use in other places in your life, but I'm having you to start to use them with your appearance-based obsessions. And then the real work comes in and I say, let's be objective. Let's take you out of the equation. And if somebody gave this assessment of the situation, what feels a little bit more rational? And often clients, especially if they're in better insight by this point in treatment. So if you're my client, you might say, well, nobody like stared at me. Nobody laughed at me. In fact, everybody at every event I went to was really polite, really kind, and hung out. Now, as Robin already pointed out, they like to say, well, everybody was just being nice. And I always tell people, no one is that nice. No one is that nice out there. Point them out to me, because even Mother Teresa had moments, right? So we can either believe everybody is so nice and all in this coordinated plan to just gaslight you and be nice, or based on what you're learning in therapy, what's a more balanced way to perceive it? And they'll say, okay, well, I think everybody was treating me well. I got a good reaction at work and at my family event. I really believe that it was because I was projecting and I was internal. And I'll say, okay, so what would be a more balanced conclusion? And they may say, when I was at these events this weekend, because of BDD, I was projecting and it made me feel uncomfortable, but objectively, people were really supportive. Then that's where the ERP comes in, because next event, what I want them to practice is to do the same things while dropping those safety behaviors, but going in there with this new insight, this new belief, and acting as if that belief was true versus their automatic thought, which typically leads to the camouflaging, the avoidance, and all the compulsions that they're doing.
Yeah, love this. So helpful. So let's go into ERP. So what does it look like? So let's pretend that my BDD focused around my nose area. Let's just say lower nose. And so prior to treatment, I had been wearing a mask often, and that's how I was camouflaging. And I really had this perceived image. We've done the cognitive distortions. I feel like I'm ready. What might ERP look like for me?
So I think we have to look at what you're doing to maintain it, right? So what are your safety behaviors? So if it's still bothering you, are you contouring? Are you spending extra time looking in the mirror? Are you still wearing a mask? Are you Googling? Are you looking up procedures? Like, what are you still doing to accommodate this thought and this, that's the thing. I think with some people with BDD, they could still be functioning. And I think it's across the board, and they could still be going out into the world. And I've had people say, but that's an exposure. I'm still like going to work. And I'm like, but you're in the mirror 24/7, and you're in your head thinking, how do I change this? And you're going on the computer and you're Googling and you're looking at TikTok and you're finding. So I think it's going to be about, specifically, if it was about your nose, like, what are you still doing to accommodate that thought? So are you contouring? Are you looking at, beauty influencers? Are you looking at cosmetic procedures? Are you avoiding going into certain lighting? Are you avoiding going out during certain times of day? Are you only standing in certain types of lighting? Are you only standing in certain types of direction? I mean, I go very, very specific. And I think that I mean, I can't say that I don't do the same with OCD, but I kind of use my personal experience of realizing, like, we can really fine tune it down to exactly the specific behaviors. What I tend to notice when I'm doing ERP is that, let's say we have 30 things on our hierarchy. Oftentimes, by the time we're really in it, we don't even have to do some of them anymore because they're just not doing them anymore. They have already moved towards a value-based life. But I find very helpful for my clients to really write it all out and to see every compulsion they're doing. And then ultimately we do the same thing of going to the least anxiety provoking first and, continue. I think a big thing for me, and I know Chris probably agree, is this reassurance seeking. I think a lot of people with BDD are constantly asking, do I look okay? Do I look okay? Do I look okay? And that for me is a huge one that I want to just try to remove initially, because I think that's a big one is very accommodating, and there's a lot of safety around that. And so for me, I often, unless it's a 10 out of 10 for someone for reassurance seeking, I try to remove that behavior pretty early on in treatment. And I know, was it the 7 p.m. rule or 8 p.m. rule? I try to have I forget, but one of those rules that Ari Winograd said, so it's getting out of the mirror. So that's always something I always try to implore clients to not be able to use the mirror. I used to give my therapist, but I need to floss my teeth and nope, you don't need the mirror for that. You don't need the mirror to wash your face. You don't need the mirror to floss your teeth, brush your teeth. And also, so all of that, sometimes depending upon how severe someone is, if it was with the nose, if they can't stop themselves from mirror checking, we may actually put a barrier there. When I was in treatment initially, I put a sheet over all the mirrors because I couldn't resist. So, these are things that, when we're dealing with the behaviors, it's going to vary from person to person. Because even someone, let's say, who has skin BDD, their stuff's going to look different than somebody else. So it's always looking at their personal experience.
Yeah, and I would say, going back to your example, Liz, I mean, the way that I look at ERP is it's an opportunity to put together everything that we've been working on. So the understanding of what's going on in your brain and why, when we go out, you may see people as taking extra notice to your nose. There's other specific compulsions that people might do. So let's say I'm working with you and I'm like, okay, you look at your hierarchy and you're like, well, I would feel comfortable going out without a mask to the Starbucks across the street from your office because it's not that busy. Like Robin said, what I think is different than OCD is there's a lot of other factors, right? So for instance, when we go out though, are they scanning to see other people's faces? Are they looking at other noses and comparing to their own nose? Are they trying to see how people react? Are they also like putting their hand on their nose, or did they wear extra makeup that day to contour their nose because they knew they were taking off the mask? So with OCD, it's a little straightforward, right? Either you touch the thing or you don't. But with BDD, there's all these other factors around the mask, putting on the mask. So let's say the client is like, okay, I'm going to make sure that I'm not scanning. I'm going to just kind of look in front of me. I'm not going to compare. As humans, we observe. You can't not observe. You'd have to walk with your eyes closed. But that's extra step of then looking at the nose specifically, comparing it to your mental picture of your nose, and then feeling less than, because that's how it always ends up. We're not going to do that. We're going to make eye contact. I want you to wear the normal amount of makeup, and we're going to go to Starbucks, order, and then come back. What I do then when we come back, similar to what we were talking to Mike Wheaton about when we were discussing inhibitory learning, is I want to talk a lot more about what did you experience, but just like Robin said, a lot more about the emotional experience. My clients with OCD come back and they're pure fear, right? Like that was a lot of fear to go over there and touch things. But with BDD, it's like, well, I feel really low. Even though I just accomplished this great thing, I feel very low. I feel like I didn't belong in society and I was an outlier when we were out there. And so it's talking about like, how did you come to that conclusion? My observations were that we were just two people going to Starbucks. So tell me a little bit about what those feelings, like what is the purpose that are serving? Ultimately, what clients will recognize is that they've been hurt. Typically, it's some kind of trauma or it's some kind of poor experience when they're younger. And part of what OCD does is BDD rather prevents them from rejection, from being hurt, from feeling less than from people. So as you're putting them out in the world and you're dropping those safety behaviors, you got to be prepared to talk to them when you get back to the office of like, the reason you felt so low after doing this great exposure is because you're kind of pushing through that safety barrier. And there is a possibility of judgment or rejection, and your brain thinks it's protecting you from that. But maybe that's not even a problem in the first place. Everything you've told me is like when you've been in a healthy mindset, you've had friends, you've had family, and you've connected. So maybe it's time to start getting out there and seeing that people might be either neutral towards you or actually like you. So there's a lot more emotional processing that goes into it.
Yeah, so a lot of learning. So tell me a little bit about how we make sure that, okay, let me back up. How do we make sure that we are not doing ERP in a way that might provoke or increase depression with BDD? So I have found sometimes when people take a more standard OCD approach of like uncertainty, and I've seen people do things like, like, for example, I had a BDD patient, a patient with BDD who had a scar, right? And they had a lot of triggers around the scar in their arm. And so obviously a lot of the work we did is just what we were talking about, right? Slowly being willing to not wear a long sleeve shirt, seeing what happens, right? What are you learning? Showering with the lights on, right? Doing these things that we're starting to remove these behaviors. But in a traditional OCD world, people might have them do things like, oh yeah, like I have a scar and everybody probably might see it. And maybe people do think it's really bad. And like sometimes if people were to do like an uncertainty script, I kind of cringe when I hear some traditional ERP folks doing these like uncertainty scripts for BDD that, like actually that might increase depression. And like, do we actually need to do that for them to get better? So kind of when we talk about, Chris, like OCD treatment doesn't need to be fear factor. We don't need to talk about our worst case fears as truth. How do we make sure we send that message that BDD treatment should be similar? And how can we make sure we're doing really values-based BDD work?
You know what jumps out to me is the notion, again, if we were to sort of write that script of I look like that scar is the worst, we're still giving the power to the scar. And I think if we go back to what we know about BDD and we know it's the visual processing issue, it sort of doesn't feel as appropriate for the work I do to go to that worst case fear, because it's sort of not about what BDD is about. BDD is about the distortion that we're seeing based upon our brain. And so to kind of go to a place of like, what if it actually is, that's not what BDD is. And I think that's why for me, I tend to not go there. I think it depends. If a person for me is just so unwilling to accept the diagnosis, and I have people that are literally not there. They say to me, Robin, I'm coming here, but I do not accept this. I am ugly. That is what it is. And then at that point, while I don't feel like I want to go there with them, but I want them to get back to a way of living, I sometimes then just entertain that for a minute and then sort of give support of, okay, so if that's really what you believe, how do we get you to live? Because you do deserve that value-based life regardless of what you see. But normally if I have a person that is accepting of the diagnosis and has a bit of awareness, and I would not, and I don't believe I ever actually wrote any of those for myself, imaginal exposure stories of like, I had bad skin and the eruption of my face. And I'm just thinking about, it probably wouldn't have helped me. I just don't know if going to that worst case fear would have even changed anything about the process for me and getting better. I mean, you could speak to that, what you think, Chris.
Yeah, the reason I don't see that as helpful, Liz, what you mapped out, is because that's already what the client is thinking. The client is already coming in and saying, like, my scar is so hideous, it's going to prevent people from loving me. So having them write that out and reading it over and over, they're already doing that before they even came to treatment. So the problem is it's almost like validating. And like Robin said, then it's putting all the power back into the scar. And so for me, one of the things I hear from clients a lot of times is that when they've gone to other treatment centers, the client has, the therapist has had the client like write out, I am ugly, I am ugly, I am ugly. Nobody finds me attractive. Nobody finds me attractive. And like you said, Liz, it puts them into a depression. And so what we're really trying to get to is those kind of scripts, or that kind of uncertainty model, is going against what we're trying to train the client in the first place. What we're trying to train the client to understand is their flaw doesn't look as bad as they think. And it's not the only part of their image. One of the exercises I do with clients is if this was you, Liz, what I would have you do is, like, I have like an outline of like a person, the front and the back, and I have somebody color a part of their body they don't like with like one color, and then with the rest of the body color the other color. And so in that case, what the client would see is like their scar might be 2% of their body. They just focus 100% on it, when in fact 98% of their appearance isn't something that they dislike or feel neutral about. So if I'm having the client reiterate that the scar is so bad and you look ugly and will never love anyone, that's going against the very like concept of the treatment. I'm trying to get you to see that the scar is unnoticeable. You have so much part of your image that is not your scar. And then further, things that Scott, Robin, and I always talk about is we're trying to get the client to see value in themselves outside of their appearance. So as we're going out, one of the other things I do when I do ERP with clients is I really focus on human connection. Let's talk to workers. If you notice a shirt that somebody's wearing, like the Angels, and you want to say that it's a cool baseball team, let's do that, because I want them to learn, like, interactions with people isn't 100% about appearance. So that's the other thing, is you're starting to transition the client into recognizing that treatment isn't all about looks. I just, unfortunately, I've never seen the uncertainty model working. And actually at our last SIG meeting, Fugan and Catherine and some of us were talking about just horror stories. And that's typically where it comes up, is like, you're ugly, you're ugly, you're ugly, your scar looks bad.
Yeah. And I would actually push, right, that it's tough, because I feel like uncertainty has gotten such a bad rap, the name, right? Because at the end of the day, we're trying, what our goal for treatment, whether BDD or OCD, is to get you to be willing to accept the level of uncertainty that everyone else already accepts every day of their life, right? Like, I might have some random thoughts or things that come up, but there's a big difference on us being able to accept that versus us feeling like we need to purposely push it, if that makes sense. And I think that even when you think about like pedophilia OCD, I don't have people write scripts anymore. We used to do this more frequently, that said things like, yeah, I might be a pedophile and I write all these horrible things. It's like, no, for values-based ERP, I'm going to have you like go to Target and be able to walk by the kids section that you have avoided for, however long now, because you're terrified for that to happen, or be able to walk your dog freely and walk by the park versus taking an alternative route, because that's a values-based activity. And we can we can get the same thing, right? And in fact, we get it in a way that feels values-based and meaningful. And I think with BDD, it's important to take that same approach, right? That we're asking you to remove the mask and go do these things you want to be doing, that is going to feel good, that you're going to be proud of, that you're going to be happy you did, and that you're going to be able to see this is getting you closer to being able to live that life you want to live, versus we're just going to try to torture you through scripts and uncertainty. And so I just want to push and remind folks that while treatment does look different for BDD, the values-based work should still always be at the core of anything we do.
Absolutely. I mean, real quick, and then Robin, once again, part of what BDD is telling everybody is that they are different, that they are an oddity, they are an outsider, and the only way that they can function is by camouflaging, fixing, or hiding. So that's why, like you were saying, Liz, the values-based exposures I do with clients is really about connection with people, getting out and getting back into things they enjoy, especially things that are not centered around looks. And the reason for that is because if my client is suddenly dating and has friends and going to family events and going to the beach and traveling, it is so much harder for BDD's message to get through. Because when BDD's like, hey, nobody loves you because of your nose, it's like, I'm surrounded by 50 people in my life on a monthly basis that your message is just not as powerful.
Yeah.
No, I agree with that. And I think that also like speaks to what you were saying with the ERP that you do with clients of like talking to people when you go out there, because I think that's a big thing, with sometimes with OCD, it's just doing the exposure. It's not necessarily bringing in an outside person to engage. And I remember myself, like, I used to work with Dr. Bruce Hyman, and, and now I get why we did what we did, but we would go to Costco and we would, I would put like red stuff all over my face, but he would have me like interact with people. And the notion also was like, it was some level of uncertainty. Like, what is that person thinking? Are they looking at you? But it was connecting also. And I think a lot of people with BDD, really retreat even internally. And that's why I feel like it's a little bit more complex, and the intricacies of even when you're doing the exposure, it's like, I want to make sure I'm not a perfectionist, but I want to make sure we're doing it the right way. Like, are we just going out and you're running away from that exposure? Or are we going out and really maximizing it?
Yeah. And leaning in and being able to see, and maybe it's fun and maybe you're doing something funny or silly and that happens, but what are you learning, right? Man, I learned that even though I had this silly design drawn on my hand and it drew people's eyes, that like they still had conversations with me, and that like, even if it was there, right? What are we learning versus also we're just going through motions, right? That's so important. And so I love it. I feel like you guys did such an incredible job of helping us see how BDD looks different, how treatment looks different, but also the similarities that exist. And at the core, what I love is that I feel like the message is just continuously crystal clear that when we sit across the room from someone, we meet our clients where they're at. If they aren't ready to dive into treatment, we shouldn't be in the treatment phase. We should be in the education phase. If they are ready for ERP and they're wanting to do it, they should help lead the way. They should help guide what they want, what would be meaningful to them, so that they're willing to do this hard work. And again, the work should always be values-based. It should never be just to see how far we should push it or to do it just because. Learning should be able to happen. And we should have a clear idea of what are we hoping you learn and what did you learn and what did you not learn. And I think that those translate and transcend actually across all therapeutic interventions, not just OCD, right? But that's what should be happening when you're doing any of this work in a space with someone at this time in their life. So this has been amazing, Chris. And, I really love both your personal and professional experience, and Robin, you as well. And so I will let y'all take the lead on wrapping us up today. I know we didn't get to questions and there's so many, so probably need a part 2.
Well, I want to just thank you guys so much. I'm really looking forward. I know Chris can give the exact dates. I'm a little bad with that, but I'm really looking forward to the BDD conference that the IOCDF is, having. And I think it's just going to be a great opportunity to have people who are struggling and also clinician side. So I think this will give an opportunity for clinicians to really see the different treatments for, what's the same, what's different with OCD, BDD. And I'm just really excited for that. I think the last BDD conference I went to was in 2005 in Los Angeles. So that says a lot. We really need to get the momentum. And I really thank Chris so much for that, because he's definitely a big push in that direction. So very grateful to have been here today to talk and to continue to spread the message about something that I feel so, emotional about personally, but always about clients and families who are struggling with this and wanting to ensure they get, the right proper treatment that exists. And I think Chris and I are a good example of what that looks like.
Absolutely. Well said, Robin. I mean, what I just want to echo is what I hope everybody got today is, if you or a loved one is dealing with body dysmorphic disorder, please get help. A first step, as Robin said, would definitely be the IOCDF's BDD conference. That is going to be Saturday, March 16th. It is from 8 to 2 LA Pacific time. So it's 11 to 5 East Coast time. It's very cost effective. It's only $25 for individuals and loved ones. There's a whole track with experts, also family members and people with BDD sharing their experience. And if you're a clinician, we're offering, I think it's 6 CEs It's $65, so it's cost effective for those CEs as well. What I love about this conference is we're doing it as a training. So especially for the clinicians, the things that you heard Robin and I and Liz talk about today, we're actually going to be role playing. We're going to be going through client cases. So it's going to be much more interactive versus just a talk. So I think you'll learn a lot. I always believe OCD therapists can be the best BDD providers because, like you said, Liz, there's a lot of similarities, but it's kind of like knowing Spain, Spanish, and Spanish from Mexico. There are some major differences. So come to that conference. It's a great time to get that information. But thank you so much. Robin and I always love doing part 2 and speaking about BDD. So we'd love to be back, but we hope you enjoyed it.
So excited. And Chris, I have a question about the conference because I'm really sad I can't go because of the date. Will it be recorded at all? And will there be opportunities for people to watch later? Like, could I pay and get recorded sessions since I can't attend live?
So I'm going to ask the IOCDF. I know as of right now, it says on the website it won't be recorded, but I'm hearing from a lot of clients, it sucks because you pick a day. We picked this date like last year, and you always think it's like the perfect date. We looked at everything, and then people are like, that's my kid's spring break. I'm going to be out of town. So why don't we update everybody next week? I'll reach out to Margaret and Steph at the foundation and see if we can get it recorded, because I'm hearing from a lot of people that they only can see half or they're not going to be there. So we'll keep you updated. Keep updated.
Thank you.
BDD.
I love this. There's such just want to kind of like have my inner Dennis Aslin and others, you know, that BDD is just, we so need to be talking more about it and offering more treatment. And it is such an incredible, the treatment works so incredibly well, right? And it is so incredible to get to watch somebody progress through treatment, just like with OCD. And so there is hope and help available, but treatment does need to be specific. It does need to be specialized. The standard treatment we do for OCD doesn't translate the exact same. There are some really specific nuances. So I also, those of you that are clinicians listening, please hear that today and take time to set your goals around what you want to learn for 2024. If it's BDD like me, like be really thoughtful about that and how we make sure we can become an even more competent and better BDD clinician. Thanks, you guys.
Thanks, everyone. See you March 16th, April 16th, or March 16th. Yes, March 16th. Darn months confusing me. March 16th for the conference.